With that said, I don't want to bore you, but what is depression? It's a collection of symptoms, right? We're not necessarily doing blood tests to diagnose depression. We're not doing brain scans. But what's interesting is, I look at the DSM-5, and that's my own DSM-5 as the kind of background there. So how many different symptom combinations can lead to an MDD, major depressive disorder diagnosis? And at a minimum, it's about 227. And once you actually break it down and you actually look at, is someone sleeping more, sleeping less, eating more or eating less, and all these subcategories, it actually goes into the thousands. So what that means is that people with depression don't look the same. We all kind of know that. But it's worth pointing out that a lot of the mechanisms at which guidelines are produced or we're asked to treat patients, some people say it doesn't matter what, psychiatrists and these clinicians, you could prescribe whatever you want, and they're just kind of trial and error. Well, our patients with depression actually can look very, very different. They could share very little symptoms. And obviously, a lot of you may also realize that there's a tremendous amount of overlap with substances, with anxiety disorders, with personality disorders, and lots of other conditions. So these categories are by no means clean categories. And I should note out, based on my medical training as well, and something that we know, a lot of our patients have a lot of comorbidity, medical comorbidity. So what is depression? I mean, is it an inflammatory condition? Because we know the microbiome and the gut and the brain are all linked. All these inflammatory cytokines and precursor neuropeptides are released by this the microbiota, the microbiome in the gut can affect brain function and cause changes in behavior. Suddenly we've got a lot of papers showing animal models doing that. So based on all this kind of clinical difficulty, is it time for us to look at our research scales? Is it time for us to reimagine them? Because we expect research scales to be useful, right? Because patients are going to fill them out, they're standardized. But what do our research scales actually show? So this was really interesting for me because I was talking to one of my friends, Eiko Fried. He's actually a researcher at the University of Netherlands. And he produced this picture for me, this picture in a minute. And I'm going to explain what that is. Because he produced this picture and I saw it and I was like, you can't be serious. Really? Because I've read all these papers and now you're kind of really changing my mind about how we're doing some of this depression research. So what he did, he took 7 of the most common depression scales that we use in research. And he outlined every single depression symptom across all these different scales. And he found 52 different symptoms. And then he looked and tried to find out how many of these symptoms are shared across the scales. Only 6 of them appeared across all of the scales. It's only 12%. And then 21 of these symptoms appeared just in 1 of 7 scales. So when we read a paper, sometimes we read the methodology, but sometimes we just want to find out, okay, what are they getting at? Let me just, if you've got 100 papers to read, it's difficult to methodologically kind of go through them in a super fine, nuanced way. Okay, what's the abstract? What are they getting at? What can I get from this paper? But it turns out that, what on earth are we measuring? What are these scales? They're very different. Some scales, as we know, can be weighted much more towards sleep, for example. And then the other thing is that, we measure these symptoms, but by no means are our patients thinking that these symptoms are the same in terms of impairment. How each symptom matters to a patient varies a great deal. So some people say, hey, if I'm cranky, that's my big issue. I don't want to have an argument with my spouse or work colleague. Or, hey, I just really need to get sleep. So what is a symptom that's actually very most important for our patients? And this stems out to much bigger issues for us. What are the things that are going to give our patients the best quality of life? And sometimes those things are employment, how they're doing educationally. And these things are often missed when people think about symptoms in a very reductionistic way. So we need to kind of find out a little bit more about depression and what's happening, but who's seeing our patients. Again, this is US data. So in the US, the clinicians most likely to see patients with depression tend to be family doctors and general practitioners. And having that background myself, it's hard as a general practitioner. I don't know if you would agree, sir, but it's hard when some patients come in with multiple different complaints, and then there's an underlying behavioral issue that may or may not become visible in a consultation. And you may be pushed for time, and you have to sometimes refer. It can be quite complicated. But there's something I want to say about this slide, because I said, who is seeing patients with depression? And I mentioned clinicians. Whereas the reality is actually quite different. This is a very, very recent paper, because no one is seeing these patients. The reality is that most of these patients aren't being seen and aren't being treated. And in a really strange way, some of them who are actually being treated don't necessarily have depression. So with that said, I'm going to move on to thinking about some of the converging paths that are really going to potentially help us in mental health.